excited. So we're going to change gears a little bit, but before we do so, can you raise your hand if you're one of the adult trainees that's here through this college? I know you, Gamal. Yep. Very good. Yeah. You guys up there. All right. I know you're fun, and Nina are here as well. So we'll kind of switch gears a little bit to focus more on the adult trainee, adult provider side of Dravet syndrome. It's a little bit different. We know a lot less than pediatric epileptologists, so that's my disclaimer. And the focus is slightly different. So just before we talk about learning objectives, I just want to take a moment to think about why do we need to know how to take care of Dravet syndrome from an adult standpoint. Just thinking it through together, I think there's two scenarios where we would see patients with Dravet. One is if they come through the transition program that we're going to talk about tomorrow with Dr. Perry. And that's the easiest route for us, I think. They come with the diagnosis, they come with the right medications. So it's a matter of smooth sailing, making sure they're addressing the issues that can come up during adulthood, but overall you have the diagnosis, you have the medications, a little bit easier. And then the second scenario will be where you actually make the diagnosis right off the bat, which is a little bit more complicated, and then it comes, you have to have a high degree of suspicion and know a lot about what Dr. Nubb told us about in terms of the clinical features. So I think those are the kind of the two routes that you can see patients with Dravet in the adult side of things. So with that in mind, it's going to be more practical what we're going to talk about today. So it's really what we as adult providers need to know when we're actually seeing these patients in clinic. Just before I keep going, if you have any questions, instead of leaving to the end, if that's okay, just raise your hand and then we can talk through it together. So pretty straightforward learning objectives. I think we need to know the treatment goals in Dravet syndrome, the measures that can be used to avoid seizure triggers, which is important more so in the pediatric side, but also in the adult side of these patients, and know what medications to treat them with and the ones to not treat them with. And then we're going to touch on a little bit of ketogenic diet and epilepsy surgery as a potential therapy as well that Gamal started to make very good points about. All right, so starting with treatment goals, I feel like this is pretty standard for all the patients that we see. I had a mentor in residency in Houston actually, who used to tell us that we need to try to get patients to be seizure free with the least amount of medications in their system to try to minimize side effects. And I think the goal for Dravet syndrome patients is very similar, with the caveat that we need to know a little bit about the semiology and what type of seizures they have so we can address them maybe a little more tailored fashion. And as Dr. Andrade will talk about later on today about Dravet in adults, as they grow older, their seizure frequencies is decreased, so it's easier to take care of their seizures compared to when they're younger. And the most common type of seizure they have are convulsive nocturnal seizures. So on that left side of the screen there, the seizure side of the screen, I think we need to try to minimize the number of convulsive seizures and the length of convulsive seizures in status epilepticus. So that would be our goal on the left-hand side there. And then with that in mind, we need to make sure that we're not giving them too much medication that would impact their quality of life because of side effects. So with kind of that balance and trying to get a nice balance between them with those two, seizure control and side effects, I think can guide what medications we can use and what treatments we can use, with really focusing on the quality of life more than anything. In terms of avoidance of triggers, the triggers are more common during childhood, as you know, less so or less prominent when they're adults, but they're still present. As we all know, fever and hyperthermia can trigger seizures in these patients, and they can still have hyperthermia and fever as triggers as adults. So trying to counsel patients and families to avoid hot baths and warm environments and overexertion for that same rationale. There's also some experts would advocate to consider prophylactic antipyretics and benzodiazepines in the circumstance of vaccine or scheduled vaccines or when they're ill, they have a fever, the so-called the Ativan bridge or the benzo bridge, then we use. So that's a possibility to consider as well. And if they have stress or flashing lights as a known trigger, it's important to address those as well and try to minimize them as much as possible. Dr. Noop already talked a little bit about this. I think this is a pretty big point that we should all be really familiar with from an adult side of care, which is really to avoid contraindicated anti-seizure medications, and those would be the sodium channel blockers. So carbamazepine, oxcarbazepine, lamictal, lamotrigine, azicarbazepine, and then phenytoin or phosphenitoin. And the asterisk is there because, as Dr. Noop mentioned, it's a little bit controversial, especially in the acute setting, in the ED, using those to abort seizure or status. We don't have a lot of data to support it or contraindicate it in those settings, so that one has a little bit of a caveat there. But overall, especially in clinic, in a chronic AED management, we usually try to stay away from sodium channel blockers. So that's the point number one that we should all be really be familiar with from the adult side of epilepsy care. Now, going back to that international consensus that was led by Dr. Urel, it just came out this year. Before this international consensus, there was a North American consensus. Now Dr. Urel took the next step to get experts from across the world and get their opinions and come up with this consensus algorithm. So I think we went over this, but I think this is the second very important point in the talk for us adult neurologists, epileptologists, to know really what to do, especially if you make a new diagnosis or if they come through transition with already a diagnosis, that you can choose those medications that are syndrome specific, or the ones that are more efficacious in those patients. So just to go over really quickly, so up at the top we have Valprocaster. We're not going to talk about it too much. I think we have a pretty good experience with Valprocaster in other patients. And then as a second tier, we have FENFLURAMINE, STIRIPENTOL, or clobazam, and the third tier is CBD, cannabidiol. And it's important to make the point that it's pharmaceutical grade. I had a patient a couple months ago, actually, in clinic that was taking CBD. She was buying from the internet, and she asked if they had the same efficacy as the one that we prescribe, so the pharmaceutical grade, and the answer is no, or at least we don't know. So the studies all use the pharmaceutical grade. And the data we have supports the use of CBD that is pharmaceutical grade, not other types of CBD. And then as a fourth tier, we have topiramate and ketogenic diet, and down the bottom we have other medications. So overall, I think it's really exciting to be treating Dravet recently because we have three new FDA-approved medications. Those would be the FENFLURAMINE that we're going to talk a little bit more about today, STIRIPENTOL, and CBD. STIRIPENTOL was actually used in Europe for a longer period of time. It was more recently approved in the States by the FDA, and FENFLURAMINE and CBD are the two most recent ones that we can use. Another important point before we talk about those three. We have more observational data and case series and retrospective studies to support the use of these medications in Dravet syndrome. So we really were in the need of more rigorous clinical trials to look for medications that are really efficacious and safe and well tolerated in Dravet. And we have those very rigorous studies for the ones that were just approved, FENFLURAMINE, STIRIPENTOL, and CBD. So I just wanted to talk a little bit about those three individually, starting with STIRIPENTOL. So like I mentioned, STIRIPENTOL was used in Europe for a little bit longer, so they have more experience than we do. And I'll show you a clinical trial from 2000 that showed very good efficacy, so 20 plus years ago. But just to start with the basics, the STIRIPENTOL works by increasing the GABA, so the inhibition in the brain is an activating effect in the GABA A receptors. It is a P450 inhibitor, so it's important to know that it does increase the level of clobazam. So if you're starting a patient in STIRIPENTOL and they happen to be on clobazam as well, which they should, if you're going with the FDA statement, you have to know that the clobazam will go up, so you might have to tweak the dose or decrease the dose to make sure they don't get toxic. It does increase the dose of FENFLURAMINE as well, so it's good to keep that in mind. And like I said, it was approved by the FDA in 2018 to treat seizures in Dravet syndrome in combination with clobazam. So it's not approved for monotherapy. And in fact, in Europe, it's approved to use in combination with clobazam and valproic acid. But here in the States, if they're on clobazam, that's sufficient. It's also important to note that STIRIPENTOL is thought to be neuroprotective as well. So there's that component of the medication. And I'll show you one study that Dr. Knoop actually showed as well, that if you start it earlier than 15 years of age, the cognitive outcomes and seizure outcomes in adults seem to be better. And that might be related to the neuroprotective characteristic of this medication. In terms of side effects, they're all dose dependent, and they're usually in the realm of loss of appetite, weight loss, and drowsiness and sedation. So just going back to that trial that I mentioned from 2000, Dr. Kieran, they got two groups of 40-ish patients with Dravet, and they added STIRIPENTOL to one arm and placebo to the other arm. So if you look at the responders up there, which, as we know, is a decrease in seizure frequency of more than 50%, in the STIRIPENTOL group, 71% were responders, so had their seizures decreased by 50%, whereas in the placebo group, it was just 5%, so it's statistically significant. And if we looked at the seizure-free patients, there are actually a difference as well, where the STIRIPENTOL group had 43% of those, and 0 in the placebo group. So that was evidence at the time that, and still, that there's other studies after this, including a US observational study that Dr. Rail led as well, that teach us that STIRIPENTOL is an efficacious medication to treat seizures in Dravet syndrome. This is that other paper that Dr. Knoop showed. I just wanted to point out, if you look at adults with STIRIPENTOL, they seem to have continued efficacy and tolerability and safety. So that's good data for us adults to be aware of. And the dose might be a little bit different. The dose in the study there was 25 mg per kg per day. And just to the second point of the study, again, if they found that if it started earlier, before the age of 15 years, the cognitive outcomes and seizure outcomes are better when they're older. That's good to keep in mind. So that's for STIRIPENTOL. Again, if you have any comments, please raise your hand. Otherwise, I'll keep going. So FENFLURAMINE is next in line here. There's actually a cool story about FENFLURAMINE that you probably know already. Dr. Elizabeth Thiel, who's my mentor and friend at MGH, told me this story a while back, and I thought it was pretty cool. Wanted to share. So again, I guess that's kind of well known. But back in the day, so initially going back, FENFLURAMINE I think was discovered or created in the 60s in Europe, and it was used as an obesity medication back in the day. And in the 80s, iCardi and Gusto actually tried to use FENFLURAMINE in a cohort of kids with autism and epilepsy that were self-induced. So they thought that tweaking the serotonergic system would potentially have the kids self-induce their seizures less and therefore improve their seizure control. So that's why it was kind of like started in the epilepsy world. But that didn't last too long, especially for the obesity side of the use of FENFLURAMINE. They found that patients would have thickening of the cardiac valves and pulmonary hypertension. So that was pulled off the market at that time, and that's why you can see the little heart there. But some groups in Belgium continued to use FENFLURAMINE to treat their patients with epilepsy, and they started to publish some very cool results that it actually was pretty efficacious, as Dr. iCardi and Gusto back in the day hypothesized and showed as well. So they went to the king, I believe, and they got a royal decree to continue to use FENFLURAMINE to treat seizures, and they got it. And again, they continue to publish to the point that other researchers started to, including here in the States and other countries in France, continued to study FENFLURAMINE, and then they came up with the 2 clinical trials that actually generated the FDA to approve this medication for us to use in patients with Dravet. That's a little bit of the backstory. I thought it was pretty cool to share. So back to the medication. I don't think we really know how it works, but there are some theories. I think the biggest one is the serotonergic effects that could potentially improve seizure control. There's also this mechanism of action, the sigma-1 receptors, that could be contributing to how fenfluramine acts on seizures as well. And there's this question about modulation of the NMDA receptor mediated excitation. It was just approved, as I mentioned, in 2020 for the treatment of seizures in Dravet syndrome. And you would think, and everybody was really worried that because we saw the cardiac valvulopathies when it was used for obesity and pulmonary hypertension, even if that would be the case. So that was part of doing the clinical trials and looking more from a safety standpoint if we're actually if it's worthwhile using it for treatment of seizures. And then I'll show you two of the clinical trials. And the good news is that no patients in the trials actually had cardiac valvulopathies or pulmonary hypertension. So that was really exciting for the community, and that led to being FDA approved. One point is that the dose used in the studies is a lot less than what it was used for obesity treatment back in the day. So that could be playing a role in why our patients, epilepsy patients, did not develop cardiac valvulopathies and pulmonary hypertension. Regardless, in the trials and still in clinical practice, and Dr. Thiel has a very robust experience with fenfluramine in her patients, it is still recommended to do an echocardiogram prior to starting the medication and then every 6 months during treatment. So that's part of the standard of care, and they have to be in a program where they would recommend all the monitoring, and the echocardiogram is a pretty big piece in there. In terms of side effects, there's some fatigue, some lethargy, some GI symptoms, loss of appetite, weight loss here and there. And then we talked about the cardiac potential issues. So just show you really quickly the two trials that I referred to that led to it being approved by the FDA. This is the first one from 2019, so all very recent, that looked at fenfluramine in patients with Dravet without not being treated with STIRIPENTOL at the same time, because as we learned, there is this interaction between fenfluramine and STIRIPENTOL. So they wanted to look at those patients that were not treated with STIRIPENTOL, just to look at the efficacy and the tolerability and safety of fenfluramine first. So this is the main figure of the paper. So you can see in the y-axis the percentage of patients, the x-axis the reduction in convulsive seizure frequency, and I don't know if let's see if I have the mouse here. I don't. But the 50% reduction on the x-axis there, there's 3 lines. So the green line on the top will be fenfluramine at a higher dose of 0.7 mg per kg per day. The blue line would be fenfluramine at a lower dose, 0.2 mg per kg per day. And then we have the placebo down at the bottom. So a 50% reduction of convulsive seizures in the study. On the higher dose of fenfluramine, it was about 70%, which is really good. And about 40% in the lower dose of fenfluramine, pretty small in the placebo group, so 12%. And that was statistically significant. And it was pretty cool, and Dr. Thiel likes to point that out too every time we talk about fenfluramine for Dravet, that they went a step further and looked at how many patients actually had a 75% reduction in seizure frequency. And this is actually pretty impressive as well. So if you look again, the green line, there's 50% of the patients that were on the fenfluramine at the higher dose actually had a 75% reduction in seizure frequency, which is really promising, really exciting. And on the lower group of fenfluramine is 23% and virtually none in the placebo group. So that study showed us that fenfluramine is very efficacious. And again, there was no big issues of side effects, including no cardiac valvulopathy or pulmonary hypertension, so it was determined that it was safe to use in the population of our patients as well. So that was 2019. Fast forward in time, 1 year later, they did another randomized double-blind control clinical trial looking at fenfluramine alone in patients that are already taken STIRIPENTOL. So let me rephrase that. It's just one dose of fenfluramine with the patients that were already on STIRIPENTOL. So different patient population compared to the first study. And what they saw was similar. So again, same graph there. So if we look at 50% seizure reduction, it was around 50% in FENFLURAMINE group at that one dose, 0.4 mg per kg per day, and almost none in the placebo group. And also at the 75% mark, which was around 35%-ish of seizure reduction. So again, very, very efficacious medications and very safe. Just a little bit more information. Adult neurologists are not used with oral solution or liquid medications for seizures too much. But FENFLURAMINE, it is an oral solution, as is CBD. That's the dose up there, 0.1 mg per kg twice a day. And we would increase every week as needed and as tolerated. And at one point to keep in mind, if they are on STIRIPENTOL at the same time, the dose would be slightly lower at 0.2 mg per kg twice a day. And if they're not on STIRIPENTOL at the same time, the dose would be slightly higher. Again, these dosages can be just looked up on UpToDate, so we don't have to memorize any of them. All right, and now moving on to the last one, CBD. Again, it is the pharmaceutical grade. That's the one we have data for and to support the use in epilepsy. Mechanism of action-wise, it's also kind of unclear and unknown. There are a lot of theories out there, but nobody really knows exactly the mechanism of action. Back in the day, I guess up to this day, some would say that it actually works through increasing clobazam levels, and that could be part of it, but I think we have enough experience now to know that that's not the only, not the main or only reason. So it acts through different mechanism of action to treat epilepsy as well. It was approved by the FDA in 2018 to treat seizures in Dravet and Lennox-Gastaut for that matter. And side effects are mainly GI related, so some decreased appetite, some diarrhea, also sometimes some somnolence. And there is that point that I think we should, I guess that's the fourth point that we should remember as adult providers that are not very familiar with using CBD. It can increase LFTs, especially in patients that are already on valproic acid. So if they're on valproic acid, it doesn't mean you cannot start CBD, but you should watch out for increases in AST and ALT. In the trials, no patients, even those that were on valproic acid that had their LFTs elevated, actually went into hepatic failure. So that was not an issue, but it should be monitored. And now just going back in time a little bit, in 2017, group led by Dr. Davinsky, that was the pivotal trial for CBD and Dravet. Looked at safety, tolerability, and efficacy of CBD in seizures for Dravet. So if you can look at the cannabidiol column there, so that's one group, and then we have the placebo group. And then inside the red rectangle there, we have the percentage in change in seizure frequency. So it was a 40% decrease of seizure frequency in patients that were started on CBD compared to 13% in the placebo group, and that was statistically significant. So that showed us that it is efficacious in treating seizures in patients with Dravet. It's also, again, an oral solution. We have the dose up there, 2.5 mg per kg twice a day, and you would increase weekly as needed and as tolerated. And you can go up to 5 mg per kg twice a day to 10 mg per kg twice a day, which I believe, or 20 mg per kg per day, which I believe is the dose that they used in the trials that we try to get if we need to from a seizure control standpoint. The other important point is that, like I mentioned, it increases the clobazam levels, but it's actually not clobazam. It's the metabolite, it's, written up with the screen there, the desmethylclobazam. So if you actually check clobazam, which I saw happening a while back, it's actually going to be normal, but it's that metabolite that gets increased. And before, that was out of order. We'll go back to that. So additional therapies, so ketogenic diet and low glycemic diet even can be used in patients with Dravet that have refractory seizures, despite all the good medications that we have these days that we talked about. Again, Dr. Teal has a huge center of ketogenic diet. She has a very good experience treating patients with Dravet for seizures with ketogenic diet. So she's a big proponent of that. And going back to Dr. Urel's paper, you can remember that on the fourth tier there, they added ketogenic diet as a possible therapeutic option. Going to Gamal's very good question about epilepsy surgery neurostimulation. I think we don't have a lot of data to say one way or the other, but I think that talking to people that are very smart and know a lot about Dravet, I think the idea is that resection is off the table, kind of basic concept. There's not one lesion that adult neurologists are used to cause the seizure, so resection is really not indicated for the most part. And it comes more to neurostimulation, and then VNS is something that we can consider. And then I guess conceivably DBS or thalamic RNS, but that'll be more on the experimental side of things. I know that MGH, they're starting an RNS trial for Lennox-Gastaut, but again, that's all in the experimental study phase data. So for the most part, I guess for us, for adult neurologists that are seeing these patients, I think VNS is an option if they fail all the other medications and potentially even ketogenic diet. And gene therapy, I'm not going to talk too much about. I think it's not something that we use day to day still. So from a practical standpoint, it's a lot of exciting stuff out there, but I'm not going to go into details. I was really cool to learn about the ASO trial that Dr. Noob showed us. That's Dr. Teal was part of that. She's really excited about it. So hopefully that will come to our armamentarium from a clinical standpoint really, really soon. In the last slide, that's Dr. Teal and I on the left-hand side, and that's Dr. Dravet that I had the pleasure of meeting many years ago, actually with Dr. Andrade. It was a party in the Canadian Dravet Foundation. And it was really, actually somebody asked me I was doing a podcast, and then they asked me if there a cool fact about me. And I said that I had met Dr. Dravet. And then they went on to say, like, what was your first impression of her? And I think the biggest, and I never thought about that way, but I think the biggest impression back in the day is how humble she is and how much she changed our field and everything she's done. She's a genius. And yet she's like super humble, low-key, down to earth, very kind, very sweet. So definitely a role model for me and probably for all of us. And I think that's all I had. So I guess if we have any questions, we have time.
Great, thank you for that wonderful review. Do you guys, anybody have any questions?
Great talk. With a lot of these medications potentially causing like weight loss or decreased appetite, and with Dr. Nupp showing weight and height going significantly down, are there any like hard stops or contraindications from like a weight standpoint or from a lab standpoint where you wouldn't start some of these medications?
Not that I'm aware of. I think Dr. Perry might have a different opinion, but I think there's no guidelines or algorithms. I think it's more talking to the family and seeing if you get a point where the weight is going down, you might tweak things here and there. But I don't know of any algorithm or guidelines out there.
This is not necessarily an algorithm, but we published that STIRIPENTOL in adults that are naive to STIRIPENTOL is not as well tolerated, so you have to lower the dose. So our adults, they, on average, instead of the 50 milligram per kilogram, they were on 14 milligram per kilogram. And the other thing that we observed as well is that they develop hyperammonemia if they were on valproate and we added STIRIPENTOL. So, because some of them did have a decrease in seizures, but parents wanted to stop the medication because of the lack of appetite, we decided to treat that with carnitine. And many patients had a decrease in the ammonia level and could stay on STIRIPENTOL.
Thank you. And then as far as FENFLURAMINE would go, which is one you would think about that a lot, the appetite suppression of that drug tends to be fairly transient. First few weeks after you start it, and then the appetite improves, and there's rarely any significant weight loss associated with it. Any other questions? Excellent. All right, thanks again.